You walked out of your diabetes appointment with a prescription and a one-line explanation. It lowers your sugar. Every diabetes medication lowers your sugar. This wasn't the real question. This video is. I'm Dr. Safa Shiari. I'm dual board certified in internal medicine and obesity medicine. And that combination is important when treating diabetes because diabetes is a metabolic disease, and some of the new medications we have for it are also weight loss medications. I spent years managing patients in their 60s, 70s, 80s, and 90s, and I've seen what decades of being on the wrong medication plan looks like, and I treat my patients the way I like to be treated. Here's what we're covering in this video. 1. How the rules of prescribing medications for diabetes have changed, because they have, and your current plan might be built on the old outdated rules. 2. The 4 workhorses for treating diabetes in plain language, and what each of them actually does in the body. 3. How I choose for a real patient. And at the end, the most important prescribing decision that I make. And it's not which medication to start, so stay for that. For decades, diabetes treatment was a staircase. You start with one pill, then another pill, then another, then insulin, presented like a defeat at the bottom of the stairs. But that model is dead, and here's what killed it. The big trials over the last decades had shown something very important. Some diabetes medication protect the heart and the kidneys directly. Fewer heart failure hospitalization, slower kidney decline, benefits that showed up somewhat regardless of how good the sugar was controlled. So the first question in treating diabetes changed. It's no longer just how can we bring the number down. It is what does your body need protected. We used to treat the number, and now we treat the body attached to it. Workhorse 1, Metformin. Metformin's main job is to tell your liver to stop overproducing sugar, and it helps your body to respond to its own insulin. It's been around for decades. It is inexpensive, and on its own, it essentially does not cause low blood sugars. The famous side effect is a stomach upset and loose stools, and most of that is solved by starting low, going slow, and using the extended release formula. Metformin is not old-fashioned. It's just old and proven. Workhorse 2 is GLP-1 class. These are the medications that include names you might be familiar with, like Ozempic and Mounjaro. They copy a gut hormone your body already makes, and that hormone has the 3 jobs. It signals your pancreas to release insulin when your sugar is high, which is why the risk of having low sugars on these medications is small. It slows your stomach down, and it quiets the appetite signaling in your brain, which patients typically describe as silencing the food noise. Many of the medications in this group carry proven protection from heart attacks and strokes, and the weight loss is real, and there is some evidence in their help in kidney protection. In my practice, a GLP-1 is started low and increased slowly, watching your sugar and side effects at every step, and it never travels alone. It comes with a protein target and exercise plan, because skinny and exhausted is not the goal. Workhorse 3 is the SGLT2 inhibitor class. You might know some names like Farxiga or Jardiance. These work in the kidney. Above a certain blood sugar level, they make you urinate the excess sugar out. The sugar-lowering effect is modest. That's not why they're famous. They're famous because they protect the heart and the kidneys. Fewer heart failure hospitalizations, and lower kidney decline. Now the trade-offs. More genital yeast infection, because there's sugar in the urine, and you need to stay hydrated. Workhorse 4 is insulin. Insulin is not a punishment, and it's not a failure. It's a hormone. Your pancreas makes it, and in type 2 diabetes, your body is resisting it, while your pancreas slowly loses the ability to keep up. When a production cannot meet demand, we replace the hormone. That's the entire concept. There's background insulin, the long-acting form, covering you around the clock. And there is mealtime insulin, short-acting form, covering food. Doses are not carved in a stone, and they move. When one of my patients lost their insurance coverage for a GLP-1 medication, we were able to titrate their insulin to keep their sugar under control and minimize their symptoms until we were able to restart the GLP-1. That's not going backward, that's just steering. And can some people eventually come off of insulin? Some can, and that will have its own video later on. And one more group deserves a sentence. There are older pills that will squeeze more insulin out of your pancreas. They're cheap, and they will lower sugar, but they can cause low blood sugar symptoms, and they can cause weight gain. They have their place. Sometimes we're limited, whether it's patient don't want to take injections, insurance coverage, or other illnesses like kidney disease. That could limit what medications we can use. But if you're taking these medications and fighting with weight gain or low blood sugar readings, that's a conversation worth having in your next visit. So how do I actually pick? 4 questions in order. First, what is your heart and kidney status? If you have heart disease, heart failure, or kidney disease, a protective class moves to the front of the line, almost regardless of what your A1C is. This is the question that changes everything. Second, which direction is your weight going? And which direction do we need it to go? Some medications can help you lose weight, and some make you gain. That is not a detail. Over years, this is the whole trajectory. Third, what is your risk from low blood sugar? If you drive for a living, you live alone, or you're older, a medication that can drop you too low is a different decision than it is for someone else. Fourth, what can you actually get? Coverage and cost are part of medicine, whether we like it or not. The best medication that you cannot afford is worse than the second best that you can. And remember, this is a simplified way because there are many other factors that I take in consideration before prescribing medication personalized to that specific person's situation. But after answering those 4 questions, then we measure. During any medication change, I want data. Best will be through a continuous glucose monitor while we're changing medications, if we can get that. Second, we'll be using a glucometer with a regular poke, and then we might need to check once a day, a couple of times a day, it depends on the situation and insurance coverage. So we're able to adjust based on what your body's doing and not just waiting months to find the A1C. However, sometimes we just have to wait until you get your next A1C in 3 months. There's another video I talk about the A1C, but just a little note here that when we make changes for the A1C to reflect the change, it does need 90 days for it to show the result of that change. It's not like we can check it sooner to see what happened. We really have to wait that 90 days. Now the part I promised. The most important decision that I make is not which medication to start. It is which one to stop. Before I add anything, I would ask what should come off. Every medication on your list has to keep earning its place. A dose that made sense at the diagnosis might be wrong 2 years later, especially once your weight changes, your food changes, or a new medication start doing the heavy lifting. Plans that only ever add is how patients end up on 8 medications nobody remembers starting. The most underprescribed thing in diabetes management is subtraction. Here's how that works in my practice. The first visit is a full 60-minute, and a complete medication review is part of it. Everything you take, why, at what dose, and whether it still deserves its spot. Then, while we're actively working, I see my patients as often as weekly or every 2 to 4 weeks. We watch the glucose data together. We adjust in real time, titrating at a pace your body sets, not the pace the insurance calendar sets. Medication changes get measured, not assumed. Before your next appointment, 4 things you can do yourself and 4 things to ask your doctor. What you can do: 1, make a complete list of everything you take with doses, prescription, over-the-counter, supplements, and keep it on your phone or better printed. 2, write down any side effects that you suspect and what time does it happen. 3, look up what your insurance actually covers from the medication classes we mentioned. So the visit starts at reality. That could spare you weeks or even months of communication or the lack of between your clinic, your pharmacy, your insurance to figure out what's covered. 4, keep the basics from the previous video titled What to Do When You First Get Diagnosed with Diabetes, and the summary include liquid sugar to 0, protein first, a walk after your biggest meal. Every medication on earth works better on top of these. And the 4 things to ask your doctor: 1, does anything on your list protect your heart and kidneys, and should it? 2, is there anything on my list that's making me gain weight or lose weight? And is there a better fit? 3, what's our plan if cost becomes a problem? 4, how will we know this is working? What number and by what date? Screenshot both lists. If you do nothing else today, put that med list on your phone and those 4 asks written down before your next appointment. And if you want a physician who would review the whole list with you and has time to actually do it, I see patients in Wisconsin and Massachusetts. Everything is in the link below. One more thing, nothing in this video is a reason to start, stop, or change a medication on your own. And that goes double for insulin. This is still education and not medical advice, and you deserve to see a physician to know what works best for you.